Μπορούμε να ξεκινήσουμε. Ξέρω ότι όλοι ανυπομονείτε. Είμαστε ήδη 10 λεπτά πίσω στο χρόνο μας, 9. Ελάτε να ακούσουμε λίγο για το EndoPredict, που είναι αυτή μαζί με άλλες υπογραφές φυσικά, εκεί που θα πάμε.
So, dear colleagues, we are very happy and we are really very honored to have here with us Professor Michael Unch, who is the head of the Clinic of Gynecology, Obstetrics, and the head of the Breast Interdisciplinary Cancer Department in the Berlin Helios Klinikum. And he will hold a presentation about EndoPredict, the advantage of a second-generation gene expression test. Professor Unch, seien Sie willkommen und wir sind ganz Ohren. Also auch am Podium. Ja.
Thank you very much for the kind introduction, also the German introduction. I will continue in English, unfortunately. My old and my modern Greek are not so good. Actually, the words prognosis must come from Greece, correct? Okay, so I'm back here. I will start with a very nice story. Do you want to hear it?
Yes, of course.
The picture on the left side was taken in 1997 when my body mass index was slightly lower. Who knows the guy? You know him? Bernie Fischer. So he passed away 2 years ago at the age of 102 years. So when I invited him in 1997 to the University Clinic of München, he gave a fantastic talk and he said, Michael, we went out as usually for a Weißwurst dinner with Weissbier and the typical Brezen in Bavaria. And he said, Michael, one day you should come and visit me. And since then, we were in very close relation. And 5 years later, I visited him and his group at the NSABP yearly meeting in Tampa, Florida. That was in 2002. And it happened that at that meeting, for the first time, they presented the data by the pathologist of NSABP, Soon Pike, of the retrospective analysis from the tumor blocks from NSABP B20 study, which then 2 years later was published as the first paper in the New England Journal of Medicine about Oncotype DX, 2004. So when I first saw the data, I said, well, very convincing retrospective data. It's a very nice prognostic tool. What about prediction? 9 years later, we published a paper in the Annals of Oncology together with Markus Schmidt. And at that time, I was member of the St. Gallen committee. And we concluded in that paper, I quoted, that neither the recurrence score nor any other currently used gene expression test has demonstrated its ability to predict a benefit from chemotherapy treatment in patients with ER-positive, HER2-negative tumors. Nevertheless, validated gene expression tests providing information incremental to established risk factors continue to be a valuable tool to identify patients with low risk of recurrence having low absolute benefit from chemotherapy. Well, the result of that was that some of my colleagues from the St. Gallen Committee, mainly from US, blamed me, how can I publish such a paper against the current of the St. Gallen spirit? Well, it was the American part of the St. Gallen spirit, not the European one. And since then, I'm fascinated by this area, and this is why probably I have been invited to give this presentation here. So one of the second generation or next generation prognostic question mark predictive tests is the 12 gene expression test, EndoPredict. Maybe for you to know, in Germany we have all 5 multi-gene assays approved and paid by the insurance companies. So we can choose which of them we use. I don't know if it's similar in Greece, but in Greece at least you have 2 tests available. 2? 3? 3, okay. Still good, still good. So we are talking about hormone receptor positive, HER2 negative breast cancer patients, and the bottom line and the topic is, and this is what I'm saying since almost 20 years, you can never separate the multi-gene assay from the other clinical and histopathologic prognostic factors, which are tumor size, number of involved lymph nodes, Ki67, and grading. It's nice from the perspective of an US oncologist to wipe out your brain and just look to the machine and say, this is high risk, this is low risk, this is intermediate risk. The world is a little bit more different, as we know. So, the risk is very simply calculated. We have the gene expression measured from the tumor and also the clinical risk factors and the histopathologic risk factors, which is tumor size, nodal status, and that gives us the EpiClin risk score. And if you see, like for instance, in this case, it's a 3.6, so we know EpiClin 10-year risk is 13%. So, right from the beginning, we were thinking about what is the best estimate to tell a patient you need chemotherapy or to tell a patient you don't need a chemotherapy. And we agreed on a cutoff of 10%. So meaning, if you have a cumulative, not a momentarily, a cumulative risk, because the risk doesn't stop in year 1, 2, 3. It can go up to 10 years and even more. So if you have a cumulative risk of 10%, then chemotherapy for metastasis, obviously, then chemotherapy gives you an absolute benefit of about between 3 and 4%, and that is something which we should tell the patient, and then the patient can decide. If the risk is less than 10%, the risks, the side effects of chemotherapy are higher than the absolute benefits, so therefore the patient should not be advised to have chemotherapy. So how is it reported? It's not just a number, but it's a combination between the gene risk, molecular gene risk, and the clinical factors. And since I worked a lot on how to give patients an information, even if a patient doesn't have an academic structure or education, you can explain every patient very simple, with very simple numbers. Don't work with hazard ratios. We can use hazard ratios here. We can use relative risk reduction here in scientific meetings. But what the patient wants to know is absolute risk, absolute benefit, and absolute risk of side effects. Period. It's so simple. So, what is my risk of 10-year recurrence? The recurrence does not stop in year 5. If you see results from a study after 5 years, it's nice to have. I always say, please wait at least 10 years, at least. Because hormone receptor positive breast cancer patients have most of the risks, not in the year 1 to 5, in the year 5 to 25. Second, what is my absolute benefit from chemotherapy? This is simple to explain, and even again, a patient without a higher education can explain, can understand that. And what is the 5 to 15-year risk of recurrence after 5 years of endocrine therapy? Because if the patient comes after 5 years of endocrine therapy, if you tell her you are cured, that is not true. It's simply not true. It's a lie. So we have to tell the patient the truth. Okay, so I was part of the validation training, the first training study, then validation 1, validation 2 from the Austrian breast cancer study group, validation 3 from the Spanish GAICAM group, then the TransAttack study, validation number 4, so patients from US, from Canada, from UK. Then the very important premenopausal validation, and the one from France with almost 800 patients. So a very large database here, and then some more prospective data, which I'm going to present at the end. We have all these 5 tests in our guidelines in Germany, so we can use them, and it's paid by the insurance companies. And these are the international guidelines for the EndoPredict, so ASCO, NCCN, St. Gallen, and ESMO 2019. Number 2, prospective. Is prospective coming also from Greece?
Oh, it's Latin.
Latin?
Oh, it's Greek and speculative is Latin.
Latin, okay. So it's a mixture always.
Yeah.
Okay, so prospective outcome study, almost 400 patients from the University of München. My colleague Dr. Klein presented them at the San Antonio meeting last year. So, median age 60, 33% premenopausal. Keep in mind, very, very important, the biology and the behavior of a hormone receptor positive cancer is different in pre and in postmenopausal patients, definitely. So, we need also data in premenopausal. More than 1/3 of the patient had larger tumors, PT2, PT3, 65% grade 2 as expected, 60% grade 3, and 24% 1 to 3 positive lymph nodes. Now the story of 1 to 3 positive lymph nodes is not about to finish, it's about to start, because it's a very important topic today. I cannot give you the final answer, but I will give you some opinion. So, you know, I'm a simple-minded doctor. By training, I'm a breast surgeon. So simple-minded. A test needs to be simple, either high risk or low risk. So 65% low risk, 35% high risk, period. Distant metastasis-free survival. 85.5 in EpiClean high, 96.6 in EpiClean low, so clear-cut information. This is the Kaplan-Meier curve, and you see hazard ratio of 4.5, so meaning those patients who have a high risk have a more than 4 times higher risk, relative higher risk of having metastasis. And again, the information is important in premenopausal and in postmenopausal patients. So premenopausal, 122 patients, and this patient, the relative risk is even higher, is almost 4 times higher if you are EndoPredict high risk compared to low risk. So clear information here that there is a very good benefit from adjuvant chemotherapy. Unless somebody wants to prove something else, I wait for the data, But this is a clear-cut information. Then, chemo benefit. Now here the story starts to be more granular, more complicated, because this is the wording of prediction. Is that coming from Greece also? No. Yes and no, that I like that. This is like St. Gallen. Yes and no. Okay, anyhow. Latin. Okay, good, thank you. Finally, somebody has to say the last word. So, predicting whether a patient has a benefit from this intervention, meaning, in this case, chemotherapy, and how high is this intervention outcome benefit, period. So you see, 89% chemotherapy EpiClean high with 89%, and those who did not receive chemotherapy because they decided not to receive chemotherapy, 68.9, so a huge absolute difference of almost 30%, and a hazard ratio, which is significant. So, we can accurately identify patients who may safely avoid chemotherapy, and we have a significant benefit from chemotherapy in patients categorized in EpiClean high risk. We have a second prospective analysis from Charité Berlin, Germany, which was also presented by Dr. Schmidt in San Antonio 2022. More than 800 patients and 0 or 1 to 3 lymph nodes. Statistically analyzed, age a little bit lower than in the previous one, 54 median, 35% PT2 and PT3, 39% grade 2, 6% grade 3, 36% 1 to 3 positive nodes, 50% EpiClean low risk, 44 treated with chemotherapy. So, again, the same story again. Benefit from chemotherapy in high-risk patients, period. And this is the Kaplan-Meier curve in the clinic in the EpiClean low risk, including, again, very important, including 1 to 3 nodes. So this is also important. An absolute risk at 2.4% with endocrine therapy alone is quite reassuring that I can tell a patient up front, you don't need chemotherapy. And the high risk plus minus chemotherapy, as expected again, much higher risk in those patients who have EpiClean high risk and do not receive chemotherapy because they decided not to get it. Now, let's come back to the story of prediction, because this is not something I want to blame. I want to openly discuss it. So, an update of the TAILOR-X data from San Antonio 2022. So please keep in mind that intermediate risk 11 to 25. And that was split between 11 and 15, 16 and 20, 21 to 25. So the conclusion from that presentation in the longer term follow-up in patients who are premenopausal. Now keep in mind, this is one of the topics I always like to look very close. These are young women. They still have little children often. So we have to really be sure that we do not expose this patient to a danger by just populistically tell them, oh, you don't need chemotherapy, it's fine. No, no, and no again. So they say no chemo benefit in 11 to 15, marginal benefit in 16 to 20, and evident benefit in 21 to 25. A retrospective analysis of a prospective study. But if we look, go to the right side to the bottom, if we look in those patients who have 11 to 25 and high-risk clinical factors, the absolute chemo benefit is 11.7%. And it's still 5.9% in those patients who are clinically low. But they are still classified as intermediate. 3 months later, in St. Gallen, Eric Weiner asked the panel one of those 200 questions, 100 of them related to oncotype, curiosity, as if in the world there is no other test. Well, was somebody in St. Gallen? I stood up, I went up and said, wait a minute, we have other tests in the world, can you remember? And that is the truth. It's not the American way of looking to the picture. We have to look it more differentiated. So, example of a premenopausal patient, 1 to 3 nodes, recurrence score less than 25, so intermediate. Well, half of the panel say chemo, half of the panel say no chemo. So if you go home from St. Gallen, you say, what am I going to do? If the experts are saying 50-50, this is not a clear-cut information. Okay. So, why is that so? In the original publication of Kevin Kalinske in the New England Journal of Medicine, you see that, number one, the premenopausal patients are a minority, 1/3. Second, most of them, if they are node positive, have 1 node, and 3 nodes just less than 10%. So be careful. My message is be careful. If you use the test in patients with 3 positive nodes in premenopausal patients, be very careful. Look at the data. And number 3, I don't know if you mentioned, but in this paper, the cutoff was 14 to 25, and here you see 11 to 25. Okay, so changing the cutoffs is something which bothers me scientifically. It bothers me scientifically. Anyhow, now comes the truth. Because from that paper, there was a clear-cut information in postmenopausal patients, left side, no chemo benefit. And in premenopausal patients, some benefit. And this is what the clinicians then started to do. And that is a catastrophe. Why? Because here are real-world data from the National Cancer Database. More than 20,000 patients from US. And not recurrence in the breast, mortality. Mortality. So the real-world data are telling us in the intermediate risk there's a clear benefit of chemo, irrespective whether the patients are premenopausal or postmenopausal. Obviously, the premenopausal have a much, much higher benefit, but still the postmenopausal have it. These are real-world data from 20,000 patients from US, from the National Cancer Data Registry. Okay, so let's come back to the Charité, that was the Charité data. So we have now key features from EndoPredict. It's a 2nd-generation test. It is definitely prognostic. I would say it is somewhat predictive, because I'm very open. I'm not just a clinician, I'm also a scientist. I like binary classifications. This is for us clinicians very important, and also for the patient, because you cannot tell the patient, well, it could be, it might be, it should be, I don't know what. I have 3 examples for you, and then I will be done, and I see that my time is not consumed, so I have some more minutes. Okay, so, and I'm using this test since more than 16 years, so I don't know, probably I have more than 1,000 patients or something which I treated with the results of this test, not alone in the context of clinical features. First example, 43-year-old teacher, premenopausal, left side breast cancer, NSD, lumpectomy at sentinel nose, PT1C, PN0, 0 out of 3. no lymphovascular invasion, no vascular invasion, no negative G2. ER/PR positive, HER2 negative, Ki67 15%. So the EndoPredict test showed us a molecular risk of 6 and a clinical molecular risk of 3.0, which is low risk. So the estimated 10-year risk of metastasis for this patient was in 5 years endocrine therapy 8%, benefit of adjuvant therapy definitely too low to give a chemo, which is 2.5% at best, and late recurrent risk 5 to 15 with 5 years of endocrine therapy 6%. So the patient decided to have adjuvant radiation, left breast with boost, and tamoxifen for 5 years. Obviously, after 5 years, if the patient thinks those 6% still risk are for her important, which I think it could be, she could continue with another treatment, because at that time, probably or most probably she will be postmenopausal. Next example is a postmenopausal patient with a high with a high epiclin risk, 68 years old retired lawyer. She was sent to us by her gynecologist in 2021. Right side breast cancer, NST, lumpectomy with sentinel, PT1B, 9 millimeter. So not so dramatic, but she had she didn't have positive lymph nodes, but she had a high Ki67 and a high risk molecular score. So her estimated 10-year risk of metastasis with 5 years of endocrine therapy was 13%. The estimated benefit of adjuvant chemotherapy is somewhat between probably 5 and 6%, and the late recurrence risk years 5 to 15, 10%. So the patient decided to have adjuvant chemo, radiotherapy, tamoxifen, and then to follow by aromatase inhibitor, and probably she will ask or receive, she's a lawyer, ask for longer therapy, endocrine therapy, which I fully support. Next one is a postmenopausal patient, N+, node positive, epiclin low risk, and 52 years old internet specialist in February 21, right side lobular breast cancer. Breast conserving surgery was planned with sentinel, but then she received mastectomy. It was multifocal, 2 out of 8 lymph nodes involved. ER/PR positive, to negative, Ki67 10%. Molecular risk 3.1, clinical and molecular risk, low risk 3.2, despite having multifocal and 2 lymph nodes. So, and we have very good data on lobular cancer too. This is very important because lobular cancer has a somewhat other behavior than the NST cancer. And late recurrence, the absolute benefit of chemo is 3%, so obviously she decided not to have chemo. And the late recurrence risk, years 5 to 15, 7%, so adjuvant radiation chest wall, regional nodes, aromatase inhibitor, because lobular, and eventually continuing after year 5, depending on the side effects. So I am at the end of my presentation. This is the clinic where I'm working. The right side is the pink lighted Brandenburg Gate, and those books that you see downstairs were inspired by Bernie Fisher. So the first one, which I issued, was in '97, and then we continued over the years. Thank you so much.
Thank you, Professor Unch. It is always nice to have somebody here who is part of the history. So this is
hopefully
not
of the future
age.
too.
No.
Hopefully for the future too.
Yeah, I was going to say that. I was going to say of EndoPredict. I have a lot of questions, but I will turn to you. Mr. Mazanat, it would be nice if we could introduce ourselves.
Yazan Masanat, one of the surgeons in England. Lovely talk, and thank you for sharing that. For example, the examples that you gave, if I'm sitting in an MDT in the UK, they don't qualify the first 2 for Oncotype DX, which is what we use. So we'll not be doing any genomics on them. And in the day that we have guidelines and protocols, if you don't fit a guideline, then you will not get reimbursed for that.
Yeah.
So the first two is a T1C that has an NPI of less than 3.4, no oncotype.
Yeah.
The second one is even NPI is less than that, also no oncotype.
Yeah.
So it's difficult to draw the line, which one to test, which one not to test.
Yeah.
Thank you.
So number one, and this is the problem, let's say, of St. Gallen and international consensus meeting always. We come from very different areas of the world with different health systems, with different reimbursement systems, and so on. And I could give you hundreds of examples. Like, for instance, in Germany, it is clearly that, just an example of many, that we clearly use in HER2 positive post-neoadjuvant with residual tumor or residual cancer in the lymph nodes, we use Kadcyla, TDM1. It's approved, and it's paid by the insurance companies. But it's not all over the places in Europe the same. And that's the same with, payment for radiotherapy, payment for oncoplastic surgery. I have seen a bill from US for an oncoplastic surgery, $500,000. I have the bill, I can show it to you. This is crazy. So we come from different systems. Okay, so you gave the example of UK. I would not live in UK as a patient. I would not live as a patient in UK, I tell you. For definitely sure. I don't know how long the system in Germany is going to function as it does. I doubt it. At the moment, it's exploding. But still, we have 5 gene signatures available. We can choose from them, like from the shelf. And we can use it in these patients, including those with smaller tumor, those with larger tumors, those with 1 to 3 lymph nodes, not more than 3 lymph nodes, so maximum 1 to 3 lymph nodes. So maybe I'm a happy guy. Oh no, my patients are happy. I'm not so happy, but my patients are happy. So the answer is, try to do your best in your own country, in your own system, with the tools you have available, because otherwise, I don't know, it gets difficult.
Any other questions? Mr. Nasioulas.
Oh, I met this guy yesterday. He's a nice guy.
I'm sure you know each other very well.
So, I will not make the same questions as yesterday. So, okay.
Don't even try.
Okay. All right. Following your speech and see that you are the test, the EndoPredict, is including many prognostic factors in addition to the genomic profile. Are you worried that perhaps these prognostic factors overweight the final score, and therefore treating patients based on prognosis, on prognostic factors, which we know they don't give information for prediction? That's... and the second question, since you are treating physician, and we know today that perhaps from those patients that you present, only a percentage of 20-25% that get benefit from chemotherapy.
At maximum.
At maximum. What are the real-world data from EndoPredict relating to this point? How many patients, based on the criteria of oncologists, they are treating today, or that are 30%, 50%? Because, thank you.
Thank you so much. So, the cut-off points are keeping me busy since more than, 35 years or something. You might remember to those old-fashioned tests, UPA and PI1. Who can remember those tests? Urokinase plasminogen activator and plasminogen activator inhibitor number 1. Okay, now. No, yeah, but I started with that. That was part of my doctoral thesis. So, I was asking myself always, why are we using the cutoff of 3 for UPA and 14 for PI1? And I had a very, very intense discussion with the statistician, with everybody and so on, because at that time I was a very young, wild doctor. I'm not anymore young, but still wild. So the cutoffs keep me busy. And what makes me, I'm not criticizing, Oncotype DX is a fantastic test, but the changing of cutoffs disturbed me somewhat. And I understand that in nature nothing is plus or minus, dark or black, dark or white, nothing. It's a continuum. It's a continuum. And therefore, I still think on those patients who in the intermediate risk might be, the premenopausal one, especially those with involved lymph nodes, 1 to 3, might be exposed to a too high risk, because if you develop metastasis, you lost the war against the cancer. So therefore, I take into account by purpose, and I don't want you to go out from this session by saying, oh, Michael Unch is now giving us an advice to use more chemotherapy. No, because the last 35 years, my whole scientific life was full of intentions to try to avoid chemotherapy. But as long as we do not have other better tools, we have to use it. And let me give you one simple perspective into the future, and therefore I want to be part of the future still, because I'm absolutely convinced. At the moment we have data from Natalie and from Monarch A, with the addition of ribociclib, respectively abemaciclib. But 90% of these patients still received chemotherapy. So we have to do in those, let's call it intermediate. We can also define by EndoPredict a risk population in which we say, I really doubt that 5% chemotherapy benefit is good enough. So why not skipping chemotherapy and give them a CDK4/6 inhibitor. So this is the next generation, and therefore I still think that for the simple clinical all-day practice, a dichotomized view like EndoPredict is more simple for me. But you know, the world is split. You know, somewhat like Porsche, some people like BMWs, some people will like electrocars from China. Well, they will not like them because they will invade us. So this is how it happens. It's my personal opinion. I don't say that I'm the new evangelist and say, oh, everybody has to use this or this. I'm an open-minded guy, and it's up to all of you to use the one test you think you prefer, period. Don't use, and this is my last message, don't use in the same patient, because that will confuse you definitely. Don't use 2 tests, because I tell you that it's getting crazy, because the overlapping. I don't know if you have such patients, but I have some, because they went to have another test, and then maybe even another test, and that makes you crazy, because the overlapping is not so high. So stay with one test, period.
One final question from Dr. Kargatsanis.
Thank you very much for the excellent presentation. I'm Andreas Kargatsanis, a breast surgeon from Sweden. My question is with regards to your role as a scientist and an academic that has been producing research, of which I am a fan of, that is applied to clinical practice. The particular literature on gene-based risk assessments is heavily skewed. This is something which is objective. The other thing is that as scientists and as academics, and in the role of some of us in the publishing business, we try to have...
Oh, it's a business. I would like to receive money for my publication. I do not.
Yeah, same here, and I work for the publisher. But I would like a comment on something that is a common problem. once upon a time, some people read the paper. A portion of them read it in depth and understood it. Now we have moved from the area that you just go and read the abstract on PubMed, a tutorial on Twitter, or something that somebody told you. This is something that leads to very arbitrary and dangerous extrapolation.
You forgot the fake news. You forgot the fake news.
Yes, I have to keep it, legit. But I would like a comment from your part on what you think the responsibility of us as clinicians to delve into the paper and understand all these nuances is before we go and apply these results to our practice.
You know, thank you so much. This is a philosophical question, and it could be the topic of a whole day meeting, especially today, what is happening in the world. Science and academia have two major aspects, and they are crucial. It's the contradiction of something. So somebody says something or publishes something, and then it's always important to try to contradict either yourself or somebody else. And this is why I think it is so important, and especially the one aspect which has been raised, real-world data. Yes, we need real-world data, we need them, and the people publish in the New England and then they don't care about it, what happens later on with what they have published. And my favorite topic, because I'm also the speaker of all German breast cancer centers, I always say the 1,000 horsepower which we produce in the guideline, I'm also since 25 years in the German Guideline Commission, the 1,000 horsepower which we produce in the guideline, let's get on the street at least 500. And it's not happening. It is not happening. This is the problem. This is the real problem. But I'm still working on it. I'm fighting for it. And the older I get, the more quiet I am. But this is also contradictory because the people who know me say, you're not getting quieter. Thank you.
Thank you so much. Professor Unz, it was really fantastic to have you here. You can see it in the audience. I do hope we'll have you here again. Ευχαριστώ πάρα πολύ.
Vielen Dank.
Ευχαριστούμε πολύ. Νομίζω να προχωρήσουμε στην επόμενη ενότητα.